Hello, friends. Hello, friends. Welcome to this new episode of the JICS Rapid Journal Review. The efficacy of steroids in severe community-acquired pneumonia has been a subject of debate and has led with spreads of equipoise. Although more than one-third of the studies have found, or only one-third of the studies have found some benefit with the use of steroids, but there were a lot of outliers and there were a lot of intricacies which led to discordance. Even recently, a meta-analysis has found that there is no effect or that there is no benefit of steroids in severe community-acquired pneumonia. However, this recent Cape Cod study, which is published in New England Journal of Medicine in March this year, has found definite benefit with a 6% improvement in the 28-day mortality. Before we discuss into the various interesting facets of this study with our experts, let us hear the study first from Dr. Pradeep Rangappa.
Hello friends, welcome to JIC Rapid Journal Review. So this week I'll be covering this very important trial that came in NEJM on 31st March 2023. This was published. So this is a Cape Cod trial, and as you see it's come in NEJM, so probably this will have an enormous bearing in the change of practice of the use of steroids in severe community acquired pneumonia. So the title is Hydrocortisone in severe acute community acquired pneumonia. So the study was done in France, and so the question that possibly all the listeners need to ask oneself is this a new revelation, or was there enough evidence even before this that there is role of steroids in community acquired pneumonia? So the simple answer is yes, there was reasonable body of evidence even prior to this trial that steroids are helpful in severe pneumonia. So there is a video that I had done earlier on. You can look into that video. So the whole body of evidence that was available is all the meta-analysis done in the past, which will take you through the whole narrative. Because rather than talking only about this, it's good to know the background. So there are good number of meta-analysis, and most meta-analysis point out to the benefit of steroids in community-acquired pneumonia. But there was no big randomized control trials. There are a couple of randomized control trials which showed signals, and some of them did show benefit in severe community acquired pneumonia. But the message that came across in the previous studies when we reviewed was in milder pneumonias, the steroids do not have a major role to play. But in severe pneumonia, where the CRPs are high, where there are indicators which are indicating that someone has a severe pneumonia, steroids have had a benefit. So we'll look into some of those key articles, and then we'll review how this article was done. Yes, this article will have a bearing on the current practice. It just infuses more confidence on the usage of steroids in severe community acquired pneumonia. So the topics that I would be just touching about is what is the rationale for the steroid use in community acquired pneumonia, and how does steroids act in pneumonia? And as you see, there are 7 meta-analysis. Obviously I won't cover in this talk about all these because the focus of the talk today is on the Cape Cod trial. So I'll just review at least 2-3 meta-analysis which very strongly show signals towards the benefit of steroids in community acquired pneumonia. And there are 6 randomized control trials. As I said, I won't touch about all these trials, at least 1 or 2 which have a good signals, because the other randomized control trials are very, very small randomized and possibly doesn't give us too much of weightage on discussion. And we'll talk about take-home message. So when you look at why we use steroids in severe community acquired pneumonia, it's just pictorial representation in a strep pneumonia. So the red ones you are seeing are the strep pneumonia. So when there is a strep pneumonia infection in the lung, in the alveoli, there is a lot of inflammatory cascade that gets sets in. And as you see, there's a lot of neutrophils, macrophages, monocytes, which enter the alveolar space to get rid of this strep pneumonia. Along with these cells, there is release of a lot of cytokines within the alveoli, which leads to a lot of inflammatory process within the lung, which leads to hypoxemia, organ damage, so on and so forth. So there is release of a lot of pro-inflammatory and anti-inflammatory cytokines and pro-inflammatory and anti-inflammatory cells within the lung in case of pneumonia. And some of the pro-inflammatory cytokines that have been identified in pneumonia, TNF alpha, which most listeners will be very familiar with, interleukin 1b, interleukin 610, And there are some anti-inflammatory mediators that get released, and IL-10 has been recognized, and interleukin-1 receptor and soluble tumor necrosis factor receptor. So these are some of the mediators that are specifically identified in local inflammation in severe pneumonia. And how does this glucocorticoids act? As you know, friends, whenever there is intense inflammation, blood gets sticky and there is microthrombi formation that happens in the pulmonary vasculature. And this has been shown in the COVID. So the glucocorticoids act on the receptors and causes activation of phosphoinositol 3 kinase. And this activation leads to activation of endothelial nitric oxide synthase, which produces nitric oxide, causes vasodilatation. Possibly that has a role in preventing this microthrombi formation, clogging the blood vessels, and possibly reduces your ventilation perfusion mismatch and some anti-inflammatory effects. So this is in essence as to how these steroids help in severe community acquired pneumonia. So we'll just talk about some of the meta-analysis. As you see, this is a meta-analysis that came from the Chinese group in 2019. So 9 trials, 914 patients, 488 in corticosteroid, 426 in control group. If you see, the death that was significantly less in corticosteroids. So which means we had strong signals, we had good evidence, especially that came from meta-analysis, which shared steroids does help in reducing the death. And this effect was even more profound. So all the boxes that you see in red are statistically significant for all the listeners. With methylprednisolone, you see the odds ratio the effect was even more profound. And the ICU length of stay also was significantly less in the steroid group. And the need for mechanical ventilation in steroid group, as you see, also was significantly less. So all in all, this meta-analysis of 9 trials shows significant favorable benefit with steroids. And if you see this forest plot, diamond moves towards favoring steroids. So then came this very good meta-analysis from Canadian group in 2015. Again, corticosteroid therapy for patients hospitalized with community-acquired pneumonia. Here they took patients 60 years and 60% of them were males. So this looked at 12 trials, 1,974 patients. And as you see, the all-cause mortality, the confidence interval is not significant. But when they took at 5 trials, which looked at patients with severe CAP needing mechanical ventilation, all the boxes in red are statistically significant for just to make things easy for listeners. So the need for mechanical ventilation was significantly less even in this meta-analysis with the use of corticosteroids. And the 4 trials looked at community-acquired pneumonia, which progresses on to ARDS, and that also was found to be significantly less in the group which got corticosteroids. And there were 6 trials which looked at the hospital length of stay, and that was also significantly less in the steroid group. And obviously, any patients where we use steroids, the glucose level goes up. So hyperglycemia was significantly more in steroids group. So the conclusions they made from this Canadian meta-analysis was mortality does reduce by 3%, but it did not attain statistical significance. But the risk of mechanical ventilation significantly came down, length of stay significantly came down, and the progression to ARDS significantly came down in this Canadian meta-analysis. So that is also very strong signal saying that steroids, yes, we had evidence. It's not like we had to wait for Cape Cod trial to convince us that steroids are beneficial. And as you see the forest plot of all-cause mortality, diamond to the left, need for mechanical ventilation, diamond to the left, and air progression to ARDS all show that steroids had favorable benefit in severe community acquired pneumonia, and length of stay also was less. So then we'll talk so there are 7 meta-analyses. I just picked up 2 meta-analyses. Then I'll pick up 2 randomized control trials. So this is a randomized control trial that came in Lancet by Swiss group, adjunct prednisone therapy for patients with community-acquired pneumonia, multi-center, double-blind, randomized placebo-controlled trial. It was a double-blind, multicentric, 7 hospitals in Switzerland. Within 24 hours, they got randomized 1:1. So the dose of steroids, just pay attention to the dose. The dose they used was 50 mg per day for 7 days, and they compared with placebo. It was done between December 2009 to May 2014. So the primary endpoint here in this randomized controlled trial, as in Cape Cod, is not mortality. It's for time to clinical stability. That was the primary outcome. So they had 785 patients which were randomized to prednisolone placebo, and the median time to clinical stability, as you saw, was significantly less in PRED, which means they got clinically better and they became more stabler, faster in patients who got prednisolone. And day 30 complications, as you see, there is signals towards getting better in prednisolone, but it did not attain statistical significance. And hyperglycemia, all studies equivocally show with steroid usage, it is very intuitive that sugars do go up. So conclusions they made in this randomized controlled trial from Switzerland was prednisolone treatment for 7 days shortens the time for clinical stability with no increase in complication. Then there was this other trial which came in JAMA, which is an Australian study, effectiveness of corticosteroid on outcomes of hospitalized patients with community-acquired therapy, stepped wedge randomized controlled trial. So this came in JAMA in 2019. So the mean age of these patients, as you see, they took sicker patients, elderly, 76-year-old, and 465 were male, 351 were females, 816 patients. This was a negative trial where they randomized between prednisolone and placebo. They looked at mortality, not negative, it's equivocal. They said prednisolone really did not make a difference with regards to either mortality, length of stay, or hospital readmission. And GI bleed was found to be little more. So this is one negative, not sort of negative or equivocal study, which as an RCT, as I said, there was no strong signal. Only the previous trial that we mentioned, Switzerland one, we showed good one, but all the meta-analysis we showed mortality benefit. So, but the limitations of this study was the baseline severity of these patients was low and only 2.5% needed ICU admission. So possibly this study may not be too pertinent or relevant to our ICU type of patients. So then this was another sort of a meta-analysis or systematic review which came in just 2019. So this is so what this article does sort of subscribe to is there are more meta-analysis than primary studies, which I already made a mention, which show a strong signal towards the benefit of steroids. And the subgroup analysis of small RCTs of less than 600 patients, if you put together and you do a meta-analysis, there they showed there was a significant improvement in mortality. And these authors also did a subgroup analysis of small RCTs. And as you see in severe CAP, this is a very important slide. Please pay attention. In severe community acquired pneumonia, the risk of mortality significantly came down with steroid usage. As you see, the confidence interval was significant. But in non-severe community acquired pneumonia, the reduction of mortality did not attain statistical significance. So this is very important. This came from Cochrane systematic review base, which basically tells in severe CAP, use steroids, it helps to reduce mortality. But in non-severe, don't use steroids. So this is a message. And the same thing possibly reflects in this Cape Cod study that we are going to discuss. And as I said, the drivers, the studies of mortality benefit is more seen in meta-analysis. Now we'll jump into today's subject, which is the Cape Cod study, hydrocortisone in severe community-acquired pneumonia. This is a phase 3 multicentric double-blinded randomized controlled trial. So here the essence is alluding to Cochrane review database, they only took severe community-acquired pneumonia. So they didn't take mild community-acquired pneumonia, where they used 200 milligram hydrocortisone for either 4 days or 8 days based on the clinical improvement. And once they started improving, they started tapering up to 8 to 14 days. Primary outcome was to look at 28-day death. And the trial, very important, the power they calculated, they had to recruit around 1,200 patients, but the trial was stopped at the second interim analysis because of the profound clinical benefit they found in the hydrocortisone group, and the authors and the committees felt that continuing this study would deprive the patient survival in the placebo group. So they stopped in the second interim analysis. This is very important for all our trainees to reflect. So how did they define severe community? So this is very important. Why we call it as a practice changing is they took sick patients and they took patients with severe community acquired pneumonia. They defined as someone who is needing NIV or who is on intubation and mechanical ventilation needing a PEEP of 5, or someone who is on HFNO on an FiO2 of 50% with PaO2 FiO2 less than 300, or someone who is on NRBM with PaO2 FiO2 less than 300, or they looked at the scoring. So there is a separate video for all my trainees to look into all the scoring tools. Here they used pneumonia severity index. If pneumonia severity index was more than 130, they called it as severe community acquired pneumonia and they enrolled for this study. So these were some of the criteria they took to determine the severity of community acquired pneumonia. What was the exclusion criteria? They excluded patients with influenza. For all the listeners, why they excluded patients with influenza is we have studies to indicate that steroids in influenza leads to worse outcomes. So that's why they had to exclude the patients with influenza. And they did exclude patients who were on mechanical ventilator for more than 14 days. And they did exclude patients who were already on steroids of more than 15 mg for last 30 days for whatever different conditions, COPD, asthma, so on and so forth. So they excluded these patients, they excluded pregnant ladies, and very importantly, they excluded septic shock who were already on vasopressors, and they excluded patients who were on antibiotics for more than 7 days prior to recruitment. So these are some of the exclusion criteria that you can remember, which was, but influenza is a very important aspect. So the message is influenza with severe community acquired, where you do biofire, you get influenza. Possibly it may not be a great idea to use hydrocortisone. So look at the baseline variables. As you see, they're equally matched. 400 in hydrocortisone, 395 in placebo, equally matched. There's no major difference between any of the baseline characteristics. And one thing I wanted to highlight in the baseline is these patients were sick. As you see, the median CRP levels was reasonably high in all of these patients, and procalcitonin also was high in this, which means to say they were confirmed as sick patients with high inflammatory markers. That is something I wanted to point out. And what was the result? I'll just show you a summary result and I'll show you the graphs from the manuscript. So 795 patients, 400. So as I said, it was stopped in the second interim analysis because the number that they had initially planned was 1,200 odd to attain a power of 80%. So 400 in the steroid group, 395 in the control group. So this, the most striking aspect is it was very strong, provocative sort of a result with all the endpoints. So they looked at 28-day death. It was 6.2% compared to 11.9% in the control group, absolute difference of minus 5.6, statistically significant. And the need for intubation in patients who were not intubated prior, which means they came with severe community acquired pneumonia and then went on to needing intubation, was significantly less in the steroid group, 18%, as compared to 29.5% in the control group, hazard ratio of 0.59, that attained statistical significance. And the need for vasopressors, where they came stable and then went on to needing vasopressors, also was much lesser in steroid group, 15.3 versus 25%, hazard ratio of 0.5, and statistically significant. All these are significant variables. And the risk of GI bleed. So the argument is some of the previous studies showed that steroid group had a higher risk of GI bleed or other secondary infections, hospital-acquired infections. But in this study, the risk of GI bleed and hospital-acquired infections were similar between two groups. And like all the previous studies, the need for insulin for high sugars was higher in the steroid group. So this is the summary findings of this particular study. And if you want to look at the graph, so this is the hazard ratio of patients who went on to needing ventilator. As you see, the hydrocortisone is a much lesser as compared to the placebo in the Kaplan-Meier curves. And the patients going on to need vasopressors also, as you see, was significantly less in hydrocortisone. You see the confidence interval statistically significant, which means the patients needing hydrocortisone or a patient needing vasopressors was much lesser in steroid group. Patients needing intubation, mechanical ventilation was less in steroid group. And they looked at 90-day death as well in this study in the secondary outcome. And 90-day death also was significantly less in steroid group, 9.3% as compared to 14.7%. Again, statistically significant if you look at the confidence interval. So in the discussion, the authors compare this study to the most recent study that came out from the US, Meduris trial that came out in 2022 in intensive care medicine, where they did a study of steroids in 584 patients, where they looked at day 60 mortality and they did not find any difference with the use of steroids because the steroid group had a mortality of 16% and control group had 18%, and there was no significant difference or benefit of steroids in this Meduris trial that came in 2022. So the authors say that probably the difference with this study and this French study, where they found such a profound difference, was the time frame between the administration of steroids and ICU admission was much lesser in this Cape Cod study, less than 15 hours. Possibly that may have given more benefit. And there were more female patients in Cape Cod study, 30.6% were female, as opposed to this Meduris trial, which possibly had less female population. And in this particular patients group, Cape Cod septic shock was excluded. That may have acted as an advantage with regards to mortality benefit, is what the authors cite as possible reasons as to why they have such a striking sort of an advantages or differences in this Cape Cod study when compared to the Meduris. So these are some of the reasons authors have cited. And they looked at day 28 discharges. As we see, the day 28 discharges in the secondary outcome also was significantly higher. So more patients got discharged in hydrocortisone group, and that also attained statistical significance in this particular study. So what were the limitations of this study? So there were few limitations. So the observed mortality in the control group was 11.9%, which was much lesser because the predicted or the expected mortality in the control group was much higher. That was cited as the limitation. And one important limitation in this is there was no effort put in to identify the organisms by doing multiplex PCR, so on and so forth tests. So the standard test that one would adopt to identify the microbes was not mandatory in this particular study. And most of the cultures they did were negative, insignificant. So there was no bacteria identified or no bug identified in almost 45% of the patients in this study, which is cited as a limitation. And the and they have included immunocompromised patients also. That is also cited as one of the limitations. So these are some of the limitations. So the conclusion at the end of this study they made was in patients with severe community acquired pneumonia. So the severe is they have looked at pneumonia severity index or someone who is on intubated or who is needing HFNO or who is on NRBM and more than 50% PA out FI to less than 300. These are the criteria they took, not stable patients. So that is a very important message that people should bear. Don't use steroid in stable community. It's in a sick community acquired because even the previous studies, this is not a revelation study. Even the previous studies have very clearly shown, the Cochrane has shown in severe community acquired pneumonia, steroids stand to benefit. But in milder pneumonia, steroids may not help and steroids may be harmful in influenza. So these are the message. So the use of hydrocortisone in severe community acquired pneumonia lowers the risk of death at day 28 is the primordial conclusions that the authors make. So thank you one and all. So the essence of this study is for me, when I look at this study, this is not a revelation because we knew this information because there were 7 meta-analyses and 6 randomized controlled trials, which exactly said the same thing that it does have mortality benefit. And we had made these conclusions when we reviewed this around 2 years back. So this only re-infuses confidence in us that yes, steroids can be used safely at the dose they have used here, 200 mg or equivalent dose in severe community. So don't use it in mild community and possibly don't use it in influenza would my take home message. So I hand over to Dr. Anirban to do the discussion and we have Dr. Agam Mora and Dr. Satyanarayana Mysore as the expert panelists from pulmonology background to take on the discussion. So thank you, Vanessa.
Thank you, Pradeep. Thank you very much for this wonderful. And we move on to the most intriguing aspects of the discussion part. And here we will try to figure out the most important aspects which the study has tried to fix, because we all know that in critical care, it is very difficult to show an all-cause mortality benefit. And this is the second randomized controlled trial on the subject which has showed mortality benefit. The systematic the reviews and the meta-analysis have shown benefit, but there can be flip-flops depending upon the primary endpoint chosen and the inclusion criteria. But coming on to the study, first, going on to Dr. Satyanarayan. Sir, when we talk about pneumonia, often the definition is very broad and very vague. Now, in this study, they have used certain parameters to identify the severity of the pneumonia. And not only so, one very important, interesting indication which Pradeep has already showed is that the benefit has been found to be maximum in patients who had a CRP of more than 15 milligrams per deciliter. So do you think, number one, that the definition of pneumonia in all studies for the purpose of research should include some biomarker, either CRP or procalcitonin or something, so that we don't mistakenly include all such conditions like atelectasis or pleural effusion or heart failure as pneumonia, which may dilute the results of observation? Dr. Satyanarayan.
Thank you. So the main thing is biomarkers should we include. Now, if we look at the inflammatory cascade, antigen binds and then you have release of IL-6. IL-6 will work on the hepatocytes and you have release of CRP. This invariably happens in most acute inflammatory conditions, let alone infection. CRP alone is not a robust marker, but very helpful in monitoring and deciding the duration of antibiotics. And this is a established truth. Now, basically, with respect to this study and the definition, the CRP has been looked on by the authors to see if there is a balance between the pro-inflammatory and anti-inflammatory mechanisms. That is, you balance on one side of the balance IL-6, IL-8, metalloproteinases. On the other side, you are looking at T regulatory cells and interleukin-10. So I think we need to take things from a pinch of salt, as Pradeep said. Dr. Pradeep said that this is an established truth with some new evidence in a particular narrow clinical setting. All pneumonias, ideally, we should consider doing CRP or procalcitonin.
Thank you very much. Thank you, Dr. Satyanarayan. Moving on to Ajit. As Satyanarayan has rightly pointed out, that CRP is one of the factors which indicates the inflammatory response, and probably a very high CRP indicates that because of this inflammatory response, the steroids might work well, or even better because it's abating this inflammatory response. But another important thing is this study is that all these patients who receive steroids, they received within the median was 20 hours, because it was within 24 hours they were administered. Now, do you think that this is also one reason why they have got such a result? Ajit, please unmute yourself, Ajit. Early administration.
Yeah. So when compared to the previous studies, the studies which are a negative outcome. So those studies, the steroids were, given, one is a milder pneumonia, mild to moderate pneumonia. Here it is very clear that it's a positive study. In this is a positive study. Here it is very clear that it's a severe pneumonia. So number one, it is going to help, in severe cases. Number two is that these, compared to the previous studies, the studies, as you rightly said, it has given within the particular time frame, approximately around 15 hours. So that could be one reason. There could be the systemic inflammatory response syndrome also, will be having some kind of, the inflammatory cascade is having some kind of a time frame, even in any sepsis. Though these are not very clearly defined. So maybe I will say the early use of steroid in this severe community-acquired pneumonia would have made a difference. That's what I presume.
So very clearly, thank you, Ajit, very clearly. So early use of steroids is one thing which makes this study distinct and stands out from it stands out in comparison, in contrast to all other studies. Number two is the other important factor in that is because in this study, identification of pathogen was not mandated. And you see that 44% of the patients, the pathogen is not known. So do you think that this can be looked up? This is a double-edged sword, or do you think that this can be? I will go to Dr. Satyanarayan next, but I will start with Ajit. That this 44% of patients were actually with unknown pathogens. What do you?
Yeah, but they have excluded. Yeah, obviously this could be this unknown. But you can even presume that we don't know those unknown pathogens were virus or bacteria. But they are clearly ruled out.
Virus or bacteria, because
it can be virus or bacteria. It can be. It is not defined. Yes. We are not sure about that. But as you said, but they are clearly excluded influenza. I presume it should be in a reasonable way. So maybe we can do the same thing. We can exclude the if you want to try this, the steroid, probably we can do reasonable test to rule out an influenza pneumonia in our patients.
Yeah, well, Dr. Satyanarayan, they wanted to exclude influenza. Influenza was an exclusion criteria, and yet 44% of the patients, the pathogen was unidentified. Yes, your comments.
I think very, very simple. What did they want to target? Why early steroid? Even if you exclude viral, the inflammatory cascade is shaped in such a way. Not every infection would you be able to culture something and prove. Basically, the strategy is to target systemic inflammation, intactness of coagulation system, endothelial cell activation, and maintaining the vascular integrity. Whilst this is being looked at, if you just exclude the most common virus, by say namely influenza, you exclude for obvious reasons, and you are presuming it to be bacterial infection. Additionally, what they could have done is looked at some of the biomarkers, as we said earlier, looking at a procalcitonin. Not necessary that every infection you would isolate.
True, very, very true. But probably that was not possible because this was a study which started in 2015 and it was suspended during the time of the COVID, and the investigators shifted to a study on the role of dexamethasone in COVID. And then they came back once the COVID abated, they came and did the study. And that is why instead of 1,200 people, they had to terminate it at 800 patients at the second the year review.
Another group of this study is that, the pneumonia diagnosis, you said the 40%, 42%, we could not have a definite diagnosis. And obviously the diagnosis of pneumonia is based.
See, the diagnosis was based on the presence of these 4 factors. Already,
and the clinical radiological factors. So whether an infected etiology, we are not very sure. This could have been some kind of aspiration pneumonitis, epilepticus and all that. Those micro loophole is also there. Yes.
But one more thing, Ajit, because they relied a lot on this pneumonia severity index of more than 130. And when you look again, you find that out of these 800 patients, only 44 patients were there who were identified solely on the basis of PSI. Dr. Ajit.
I didn't get your question. It's only
the
800 patients.
Severity index, which was used as a criteria to judge the severity status of pneumonia of more than 130, would be possible to be used in only 44 patients, which is a minuscule of the large of that 795 patients that they analyzed.
Yeah. So I presume that the mortality is determined by the systemic inflammatory response syndrome.
No, what I want to ask, well, I move on to Satyanarayan. Dr. Satyanarayan, how useful is pneumonia severity index in this regard when you see this?
So I think trial or no trial, everybody would like to know how well the patient is faring. So in that way, PSI is quite important. But maybe a subset analysis of those who were culture positive, you could have done the PSI, looked at their PSI separately and reported. So also now 2 important factors, if you permit, I will mention them. One, there were a lot of benefits in the female gender alone, which is not explained. Any trial, if you terminate early because of the benefit, it needs to be weighed very, very carefully. If there is a harm factor evident, then yes, you stop the trial, terminate the trial very early. But if it is about the benefit, you need to carefully look and see what would have, unrolled with further recruitment. And that, I think, is a fair criticism across all the journals on this particular study.
Very, very, very true. Very true. Let us check into some of the questions we are receiving in our chat box. Some Vijay KC writes that excluding patients with septic shock, do you think it overestimated the positivity of the study? In fact, I think that it could exclude patients with septic shock is one of the biggest strengths of this study, because it could reduce the number of patients who would have falsely migrated and whom results would have been shown to be benefit, and they would have shown that the exaggerated results in favor. So I think that is a strength of the study. That, in fact, another question comes from that at what day of illness steroid was started, and this we all know that it was started within 24 hours and the median was 20 hours. But one thing I want to ask again, Satyanarayan, that they observed the patient was reviewed on day 4. On that basis, whether the SOFA score was less than on day 4 than on day 1, and on for those factors, whether the patient was breathing spontaneously, it was decided to give a steroid for 8 days versus 15 days. Now, do you think that is a reliable strategy, or that is a proven method of determining the duration of steroids?
I think we need to understand the intent here. And the intent is fairly and squarely dependent upon the physiology. So the inflammatory cascade happens very early. That is one of the reasons somebody in septic shock, it's already so pro-inflammatory that there is no role for steroid at that point other than supplementing the adrenal reserve. So early steroid is probably the way to go, and that is why they gave 4 days and reviewed, and the 4 to 8 day fluctuation is explained on that account.
Fine. Another question which our from our chat box we are getting, like COVID, can we use IL-6 or D-dimer to identify patients to who give steroids? Probably we are stretching it too far. A simple CRP value can be a good indicator, because if the CRP is high, it indicates that the inflammatory response is high and the success with steroids is likely to be more. Another question that I can see on the chat box is that the percentage of COPD patients higher in the placebo group, if they got any placebo in the management, could explain influence the results. Well, I think that the COPD patients, all those patients who were receiving were on steroids for more than 7 days or on prednisolone, were excluded from the study. And even COPD or no COPD, if they're not on steroids, probably because it's a randomized controlled trial, so they can have the equal distribution in the two groups. Another question comes from Alex Matthew. What about the placebo effect or lack of steroids in bronchodilation influencing the results? Well, I think the patients are equally distributed in both the groups, because the patients are randomized at the time of hospital admission. And therefore, which patient will the chances of will be equally distributed in randomization. So we relating to other questions. So we are covered most of the other questions that Maninder Kaur asked. Was there any concomitant use of nebulized steroids in any of these studies? Well, concomitant use of nebulized steroids may be there, because the standard of care was continued in both the groups totally as per A, and it was not influenced. And because the patients were randomized and both the groups received the standard of care, the influence of nebulized steroids will be equal in both the groups, and hence it is not a factor to be considered. Now, another question which Harun asks is on which day steroid to be started and for how long to continue. I think that is again a very difficult question for how long to continue. We know that if we start the steroid early, as the study has shown that it produces good results, but how long to continue is probably difficult. Will you take on that, Ajit? I will follow it with Pradeep Rangappa, because he has joined now. Ajit, how long you want to consider steroid if you consider the study results?
No, as per this study, the steroid was given 4 days versus 8 days. That's what I understand from the discussion here. 4
and
8
then
days.
It was tapered. It was tapered.
It was tapered. Yeah. So whenever your patient is, in this case, it's up to the clinician decided after 4 days of steroid, he has decided how long it has to continue. I believe it depends on various parameters, including the systemic inflammatory response syndrome, what the clinician must have indirectly assessed, and you could have made a decision on that. But again, the message will have been that we would like to stop the steroid also the earliest possible. At the earliest possible, we would have tried to stop the steroid.
Yeah, so that's fine, because you know that they have found that the use of insulin has been also very higher in the steroid group. One interesting thing Justin Gopaldas has pointed out, that pre and post-COVID, because this study spanned over pre-COVID to the post-COVID era, this pre and post-COVID use of steroid can lead to a steroid bias. Now, I think that's quite a possible thing, and it's a very genuine yes. What do you think about it, Dr. Pradeep?
Thanks, Anirban. In all the discussion, I think with regards to the duration, what Ajit said, it's all based on the improvement. If ARDS, we usually tend to wean. But with coming to the question about the previous pre-COVID and post-COVID, nothing has changed for me, honestly, because all the trials that analysis was pre-COVID, Anirban, and Meduris regime, which came around 2 decades ago for years, was also around 2 decades back. And so steroid has always been there on the background, and Satya would allude to that. Technologists also have always faced steroids, at least in severe cases, because of anti-inflammatory. Something has changed. If at all, in COVID, it became a saving grace, Anirban, because initially we were dreading to use. Maybe we were trying to extrapolate the influenza data to the COVID, but really it had helped.
No, that's why.
And we started using inflammatory markers, which was the point of discussion.
Yeah. So very, very rightly you have said that, and I think Justin's fear that it can lead to some bias, because after COVID we saw a lot of positive results, and there was a lot of positive reinforcement about the use of steroids in community-acquired pneumonia, be they be viral. But still, then I think that because this study didn't continue much after COVID was over, and ultimately, so they asked. Karan Vishnu asks that why did they include only 800 patients from 6,000? It was not 6,000. They actually
don't.
enrolled, and after that, their sample size was 11. They wanted to enroll 1,200, but after 800 in the second interim analysis, they found that additional 400 patients would not change the results much. There was already 6% benefit, and for that reason, they decided the study was stopped. So prematurely. So that is why dose of 200 milligram per day? Well, that's another question. Anybody like to take that? Yes, Dr. Satyanarayan. Question Dr. Amita asks is that why a dose of 800 milligram per day was chosen?
I think
Yes, Satyanarayan, you please go ahead.
Yeah. So I think number one, very interesting questions coming through. When we say mineralocorticoid versus glucocorticoid, there is a Emory University debate saying that most studies used mineralocorticoid and we want to use glucocorticoid. So that changes the game. That is one point to remember. Second, the criticisms of this study is that the 200 milligram infusion is not a physiological depiction of how the body would supplement itself during a crisis. I think the only reason for using 200 as an optimal dose, I think the definition is not very clear on that in the study. But
I think there is a convention because other studies have shown, because we had similar results. 200 milligram per day has been used. It is not the first time that 200 milligram per day was used. And we had Dr. Pradeep, why dose of 200 milligram per day was chosen? What if someone asks you as a plain and simple question, what would be your immediate answer?
Yes. See, the immediate answer is, any steroid, we use the equivalent dosage. I use it dexamethasone or use it hydrocortisone or use betamethasone or use prednisolone. I think the equivalent dosage of 200 mg would come to around 8 or maybe a little more than that of dexamethasone, and 40 mg of prednisolone, 34 mg of prednisolone, and so forth. So it hovers around that sort of a safe dosage. And the reason why we stick to this dosage of 1 mg per kg of prednisolone is most studies have shown, Satya can possibly give his comments, that at this dosage, there is no significant risk of infection with this dosage. Once you go above this dose, like more than 2 mg per kg, because this was very clearly shown in ARDS trials, that if you go up to 2 mg per kg, then the risk of secondary infections were significantly higher. So at 1 mg per kg or less, and even the dexamethasone that we used in COVID at around 8 mg, at that dose, the risk for secondary infections was always not found to be higher. So Satya's comments would be very valuable in this as well.
Yeah. Yes, Dr. Satya, very.
So I think looking across all the trials and you look at the conversion factor, you want an optimal dose that is effective in stopping the inflammatory cascade, but at the same time, you don't want to overdo it, bringing in various complications, including escalation of infection, glycemic disturbances, and other things. So I think 200 may look arbitrary, but looking across the trials and you look at the steroid conversion between one to another, 200 seems to be optimal.
So that's fine. So we have used in before. Another question which comes from Harun.
Maybe based on the use of steroid and septic shock, we have been it has been found to be reasonably safe. That dose.
That's true, because it was this.
And basically based on the previous trials, yeah. So
previous trials.
Yeah.
But one interesting one question that comes from Harun is that after how much time after waiting for how much time if we get a favorable response and beyond which we can conclude that steroids are not working? Well, that is for anybody to guess, but probably I can say that indicators of response are manifold, and that the patient is improving is evident even within 48 to 72 hours. So once the patient starts improving, as they have noted on day 4, so after 72 hours, anytime after 72 hours, if you think that the patient is improving and an overall patient is this oxygen requirement is coming down, need for mechanical ventilation is coming down, so probably these are fairly good indicators to show that the steroid is working. And if they don't happen, then probably you can still stretch your steroids a bit more, but ultimately you will have to continue. But other than that one, let us if we see into what Maninder Kaur that asked that was there any kind, well, we have answered that. So we have answered most of the questions either in some form or the other that was there in the chat box. And we have already exceeded our time by good 15 minutes. So before we close today's discussion, we want to have last words from each of our panelists. I will start with Ajit, then I will move to Dr. Satya, and finally I will end with Dr. Pradeep Rangappa.
Yeah.
Yes,
So that's
Ajit.
it. So I believe that steroids are going to give only a modest benefit. Whatever, if it's a minimal benefit, I will say minimal benefit. If at all the benefit is very minimal, it's not going to make very explosively. That's the large benefit is not there. There isn't any term, any of the endpoints. Number one. Number two is obviously I would like to use early use of steroid in patients with severe community-acquired pneumonia. And if there is no contraindication for use of steroid, immediate significant contraindication is not there, I would like to use it based on all these trials. But I don't believe that this is a remedy for everything, and this got a modest benefit, minimal to modest benefit. That's what I would like to say.
Great. Dr. Satya.
Yes. Very interestingly, 1950 era is where antibiotics came into vogue, into extensive use and misuse. But at the same time was the discovery of steroids in medical use. Now, if you look between 1950 to 2000, no additional reduction in mortality than what early antibiotic therapy could establish. So the trials have been trying to look to give shape and dimension to rational to using steroids in required condition. This study is welcome. It just adds an additional evidence. Does it change my practice? No, it may not, because this was being done earlier as well. So only thing is, it will give a sense of rationality when we use. It will also set some boundaries when not to use. Thank you.
Pradeep, your last words, final comments.
Yeah, so Anirban, as I've already mentioned in the narrative, that this article was nothing new for me, at least, because the steroids we were using in various formats in our severe ARDS, and we have also published a paper from our own ICU of the usage of steroids in ARDS. But it gives me little more confidence in using in even non-ARDS in severe pneumonia who come to ICU, who are needing NIV or who are needing HFNO. It has given me little more confidence. And at this dose, I'll be a lot more. But I'll be wary as to why Meduri's trial did not show this effect as opposed to the French group. And this, you have to bear in mind, every listener, this study was done over a very long period of time. I don't know if there were a lot of other confounding factors which possibly has not been addressed, why such a phenomenal effect was seen, because Meduri's regime was exactly similar, but they did not find any effect. So maybe perhaps we should do more studies, as many were typing, whether the phenotypes and genotype of Indian patients may be different. Maybe it's good we do a multicentric study in India to see if the same profound effect can be seen in our patient. But until then, I would use it, and definitely not in influenza and not in mild pneumonia. In severe pneumonia, I would use it, Anirban.
So thank you, Pradeep. So as you can hear, friends, people are equivocal in the fact that this study has only highlighted the use of steroids. The steroids have been used earlier before, but probably we'll continue to use in sicker patients, in patients who have a profound inflammatory response with showing a raised level of CRP, procalcitonin, etc. And it has to be used early. And when used early, we will have to be also taper down based upon the response. So this is what we had. And as Pradeep has told in the end, that whether the replicability of the study needs to be shown, because this is a French study that are only 51 ICUs in France, whether the same, if it is repeated in India or in US or any other part of the globe, whether it will produce the same results is not known. Probably phenotypic and genotypic variations can also influence the results. But over and above, it is known that this study has also put forth the randomized controlled trial in proving that there is mortality benefit if the steroid is used, and they have found this benefit at 28 days, which is also carried forward at 90 days, but still a lot more results may be coming because this is a platform trial. So we are going to see the effect of steroids in the coming days on other patients. The study will continue because the COVID cap study and some other studies are also still continuing.
Remap, I think remap study is coming. So I think we should look out for this remap study in non-COVID, because there was a COVID study. Now, we have a remap.
And that is also there. So thank you for being with us. from all of us in this rapid journal review of JICS, Shubhratri, Shabar Khayat, good night. Till we meet again.
Thank you. Thank
Thank
you,
you, sir.
Anirban. Thank you, Satya. Thank you, Ajit.
Thanks,
Thanks all
thanks.
the
Thank you.
people who joined this
Thank you.
meeting. Thank you all.
Thank you, sir. Thank you.